Today, my topic is on the drooping eyelids or blepharoptosis, its evaluation and planning of the treatment. Are my slides visible? Thank you. Thank you. So, evaluation of ptosis, the main points are we need to diagnose the condition, we need to do systemic evaluation, and then we need to plan the treatment. So, first is to rule out pseudotosis. Like in this case, there is a lid retraction on the other side. That is why this eye looks little bit of ptosis. And in this case, there is proptosis, but there is little ptosis also on this side. So pseudotosis is seen in enophthalmos of the same eye or a hypotropia of the same eye, or otherwise lid retraction or proptosis of the other eye. In cases of hemifacial spasm also, there will be a pseudotosis. So first, for evaluation, we need to keep in mind three measurements. One is the palpebral fissure height, second is the LPS action, and third is the lid crease height. And then we need to keep in mind about three muscle actions. One is the superior rectus action, second is orbicularis muscle action, third is the frontalis muscle action. So palpebral fissure height, we need to measure using the scale, which is kept vertically in the pupillary axis, vertical pupillary axis. And the distance between the lower lid and upper lid, that gives us the palpebral fissure height. And when we do a levator muscle action, we need to first ask the patient to look down and place the thumb firmly on the frontalis to negate its action. Then ask the patient to look up to the ceiling. So the excursion of the upper lid from the lowest point to the upper point gives the amount of LPS muscle action. And this is the lid crease height. And then Bell's phenomena. So there are three phenomena also we need to measure. We need to um, measure the Bell's phenomena. We need to see whether there is any Marcus-Gunn jaw winking, and we need to see Cogan's twitch sign, which is seen in cases of myasthenia gravis. And then various other measurements like if there is any abnormal head posture, how is the corneal sensation, and whether there is lid lag and lag of thalamus. So in this case, this is a lag of thalamus on this side, and then you see lid lag here. And then when evaluation, often we need to do a fatigue test that is apart from Cogan's twitch sign. This is for myasthenia gravis. And then we need to measure MRD1, MRD3, and MLD also if we wish, not mandatory. And in systemic evaluation, we need to see whether there is any frontal balding for cases of myotonic dystrophy, how is the CVS status, and musculoskeletal anomalies. This is the MRD1, which is margin reflex distance from the center of the reflex to the highest point of the lid in the vertical axis. That is the MRD1. And then MRD3. This is from when the patient is looking up from the reflex, corneal reflex to the upper lid margin. And this is the margin limbal distance, MLD, which is from the 6 o'clock limbus to the upper lid margin. So these are the various normal values. Palpebral fissure height in males is 9 to 10, whereas in female it is 10 to 12 millimeters. And lid crease height is generally around 5 to 8 millimeters. Now, in this is an interesting phenomena. Here you see there is a lid retraction on one side and ptosis on the other side. But if you close the ptotic eyes, you see the retraction comes down. The lid is now not retracted. This is a case of pseudo lid retraction, which is due to increased innervation due to Hering's law, to the increased innervation from this side to this side, as per the Hering's law. How to grade the ptosis? Mild ptosis is when ptosis is 2 millimeter or less. Moderate is when it is 3 millimeter, and severe when it is more than 4 millimeter or equal to 4 millimeter. So how to grade the levator action? So poor action if it is lid excursion is 4 millimeter or less, fair when it is 5 to 7, good when it is 8 to 12, and excellent when 13 millimeter or more excursion is seen. How to classify the ptosis then? So if it is present since birth, there is lead lag and LPS action may be poor to moderate. It is a congenital simple ptosis. If jaw winking is present, then it is congenital Marcus-Gunn jaw winking ptosis. If ocular movements are limited, then it is congenital third nerve palsy. And if there is telecanthus and epicanthus, then it is a blepharophimosis syndrome. If the lid crease is high and LPS action is good, then it is an acquired case. It is a aponeurotic or a senile ptosis. And if it is all ocular movements are limited, then it may be a CPEO, which is chronic progressive external ophthalmoplegia. And if fatigability and Cogans are positive, and in presence of diurnal variation, most likely it is a myasthenia gravis. So this is a case of blepharophimosis syndrome, telecanthus, epicanthus inversus, sorry, epicanthus inversus, and ptosis. And this is aponeurotic ptosis. You can see the lid crease is gone up here and the severe ptosis, but the LP section is good. And this is called pretarsal thinning. And this is blepharochalasis. If you see this kind of lid edema develops, and because of recurrent lid edema, the skin becomes this type. This is called cigarette paper wrinkling, and the ptosis becomes severe. And this is third nerve palsy, where there is a uh, exodeviation. And this is a mechanical ptosis seen in this is a kind of neurofibroma. Capillary hemangioma causing a mechanical ptosis here. And this is declaved adenitis, typical S-shaped contour. And then once again, we need to do proper examination to rule out masses, which was producing a ptosis. The timing of surgery depends on cooperation for examination and whether there is a chances of amblyopia formation. And we should do the surgery before the child enters the school. And various amount of levator resection, that is one formula for correction. And then another formula is like this. For a mild ptosis with good LPS action, we need to do Fasanella servate surgery. For moderate, for fair, and for poor LPS actions, we need to do LPS resections. And for severe ptosis with fair or poor LPS actions, we need to do sling surgery. There's another method. This is called Burki's nomogram. This is for decision making and during the surgery. Another method is amount of LPS resection, how much you should do MRD 3 into 3 times or MLD into 3 times. The investigations mostly penicillin test. This is for myasthenia gravis. So it is considered positive if there is a improvement of more than 2 millimeter in the amount of ptosis. And but more simple than that is a simple eyes test. Keep an ice pack for 5 minutes over the ptotic eye, and if the change in palpebral fissure height is 2 millimeter or more, then it is positive. CT scan for masses, and then in this case, you see there is a mass infiltrating the superior rectus and LPS complex. That is why ptosis is there. Another case, severe ptosis, but you see the mass which is present on the superior orbit. That brings me to the end of the topic. Okay, any questions? Thank you very much. Thank you. Thank you, ma'am. Thank you. It was a nice program.
Right. Ranchi, the leadership program tomorrow. After that,